Universal health coverage cannot be achieved unless countries fully integrate sexual and reproductive health into their broader health systems. In order to successfully integrate sexual and reproductive health services, we must include all relevant stakeholders, including women and girls and other key and vulnerable populations. I'm Sarah Barnes, and you are listening to Friday Podcasts, hosted by the Wilson Center's Maternal Health Initiative. In today's episode, we bring you highlights from our recent event on engaging stakeholders to realize health equity worldwide and how sexual and reproductive health is essential to achieving universal health coverage. In this episode, we feature commentary from Ruth Morgan Thomas and Zindili Simelane. And for your awareness, sexual and reproductive health is often referred to as SRH and universal health coverage as UHC. Both of our speakers will use these abbreviations during their remarks. Ruth Morgan Thomas has been involved in sex work advocacy for more than 40 years and was one of the founding members and is the global coordinator of the Global Network of Sex Work Projects, or NSWP. She currently also co-chairs the UNAIDS Steering Committee on HIV and Sex Work on behalf of NSWP and represents them also in the recently formed Sex Worker Inclusive Feminist Alliance. Zindili Simelane is a 27-year-old HIV and AIDS activist and self-proclaimed positive living ambassador. She is a young, active citizen dedicated to changing the mentalities on the subject of living positively with HIV. She is working towards normalizing conversations around living with HIV through HIV disclosure. This episode of Friday Podcast was made possible through the generous support of UNFPA. In these opening remarks, Ruth and Zindili both speak about the importance of including marginalized groups, like sex workers and young people, in health services and sexual and reproductive health advocacy. Ruth also discusses the harms of criminalizing populations, and Zindili discusses her experiences after being diagnosed with HIV.
I just want to start with a little bit of an introduction to NSWP because it's going to be new to many people and it will set some context. So NSWP was founded in 1992 to promote both health and human rights of sex workers, female, male, and transgender and non-gender conforming. And that's an incredibly powerful group of people. I think for me, we've worked as NSWP a lot around promoting health, around engaging with WHO on guidelines development for HIV and STI, prevention and treatment. And we help WHO, UNFPA, UNDP, World Bank, but we developed the sex worker implementation tool. And throughout all that advocacy, we've had to really strongly advocate for the need for sexual and reproductive health in a broader view than just the simple HIV and STI lens. Too often, my community have been missed out of reproductive health, either by gender or by that we're not fit to be parents. And neither of those are exclusionary from SRHR services. So I think it's really important that we actually look at then, if we're excluded from SRHR, where is the equitable access to UHC? And why are we facing those inequalities? And for those of you that follow UNAIDS, the new Global AIDS strategy has put criminalization of key populations. And by that, we're talking about sex workers of all genders. We are talking about people who use drugs of all genders. We are talking about gay men and other bisexual men and other men who have sex with men. And we're talking about transgender people, both trans men and trans women. And the one thing we all have in common is criminalization. And I think it's really important that we actually understand what is it that prevents us from accessing health services. Because that criminalization underpins and exacerbates the stigma and discrimination that my community certainly experiences when accessing health services, when being arrested by police officers, often not to be charged and taken to court. And much of the sexual violence and the physical violence that my community experience actually come from the very people in countries that are meant to protect us, from law enforcement officers. And that research is across all the regions. And we currently have 295 members in 96 countries around the world. So while I may be a white British person sitting in the UK talking to you all, the network, the majority are from global south countries, from lower and middle income countries, where the situation is really dire and there is little rule of law for my community or protection of law. I think the other issue for me that COVID-19 has exposed and will continue to expose for some time to come, I think is the exclusion of sex work being recognised as work. So for many of my community, sexual and reproductive health is an occupational health issue. It isn't just sexual and reproductive health. It's actually about our work and keeping us safe in our work. And unless sex work is recognised as work, we don't get access to the social protections that have been offered to many other people. And even in a country where sex work is legal, in Nevada, in the USA, the US emergency response to COVID excluded even people who work legally and pay taxes in that country from any of the emergency relief. So I think the structural barriers are quite huge for my community. And I'm hoping that we can, as we advocated as UHC, that if we truly mean that we're going to leave no one behind, we actually have to put the last mile first. And for many of us, the people that will never be considered by governments introducing UHC, it is the very people who are actually criminalized by those very same governments and who fail to offer protection of law, protection for social protection, and both natural and health emergencies that arise.
The population of Eswatini is a fairly small population with just over 1 million. And I think I can confidently say that young people are aware of the services available to them. And we see glimpses of that through the 95 global HIV target that Eswatini has reached a whole decade in advance. So in as much as they do cover a small fraction of the people targeted, but there is a sense of awareness. Now, the challenge comes with the gaps in between through their awareness. So they are aware, but now the gaps, we're looking at things such as inadequate skill and competence among health providers to deliver this SRH services. Now, as a young woman, I experienced this sort of discrimination or challenge when I try and access my antiretroviral treatment as a young person living with HIV and trying to empower the young girl and young people to sort of continue and adhere to their treatment. So the biggest challenge here is that the health professionals are judgmental, and of course they are our mothers, which means the cultural barrier at this point has no boundaries. Now, you're a child even at the health center, unfortunately, as a young Swazi woman, and therefore you'll be taken to task for requesting the Implanon contraceptive, because why are you having sex in the first place? You know, this automatically disinterests the child or the young woman in actually trying to access the services that they are rightfully should be having access to. Okay. Another challenge that is an issue is the absence of the conversations in classrooms where they spend most of their time, and at home, of course. Again, this is yet another cultural barrier that does see young people not being able to be comfortable enough to even inquire more about the services that they need. And I think another thing which is a bit of a challenge is the family planning terminology. And I say this because family planning translates differently to a 16-year-old who isn't planning to have children, but needs information on HIV testing, where all these have been integrated into one and put under the same roof. For instance, at the Family Life Association, where is by far one of the only centers that provides a youth-friendly services for me. So now automatically, because there's the family planning element to it, it sort of filters the young person in attending, because that's not what they want. So I guess the terminology somehow there has an issue. Is the government doing anything? Is it assisting? Yes and no. No, because abortion in the Kingdom of Eswatini is still illegal. However, in 2012, in October 2012, about 1,000 young women were seen for abortion-related complications, which means this is quite evident that there is an issue there, and there has to be a need and contribution from the government in changing this. And what I would think should be done is quite a lot. For instance, investment in guiding tools for healthcare providers and how we go about engaging the youth in a comprehensive way, and emphasizing the need to dismiss the cultural barrier. So I think these healthcare professionals should be taken to task and put into, and really understanding the importance of how they should deliver these services to these young people without pushing them away, right? And there's also community intervention. I have previously worked with Young Heroes, and Young Heroes has 2 interventions that really strike me, and I felt they were very impactful and did change to the barriers that we are facing as young people living with HIV and not living with HIV. One was Insiga ya Kusasa. Insiga ya Kusasa means the pillars of tomorrow. Insiga aims to prevent new HIV infections and to reduce vulnerability amongst orphans and vulnerable children and adolescent women in the Kingdom of Eswatini. It helps those who are HIV negative remain HIV free and supports those who are HIV positive in leading healthy lives, as well as the Health Project. The Health Project aims to halt the spread of HIV and reverse its impact on the Swazi society by targeting youth aged 15 to 24 who are out of school. Now, we've seen those young people being neglected because of being out of school and not really having an understanding of the services available to them. And lastly, media and social media, which is my biggest playground as a young woman. 10 years ago, when I tested positive, it dawned upon me that young people are actually on social media. They are trying to engage and with amongst each other. So why not bring the information that they need to them on these social media streets? So my social media pages mainly involve content about self-love, living positively with HIV, thus promoting HIV disclosure as well, and discussing the importance of HIV prevention, and often narrating the trips to the ARV department or a healthcare service, so to normalize and reinstill that it is okay to go to the healthcare center, right? As well as whether it is sharing the other options of HIV prevention, PEP and PrEP, which is not so familiar. We've seen quite the gap there because there's often questions after sharing. There's often questions that where can I actually access this type of prevention method?
In this segment, Ruth speaks about how sexual rights are commonly excluded from sexual and reproductive health, in that to truly achieve universal health coverage, all aspects of sexual and reproductive health and rights must be included.
The failure to recognize sexual rights within the SRH without the R, I think, is really harmful to UHC. When you are denied your sexuality, when your gender identity is denied, as we're increasingly seeing today, there is a whole movement that is challenging gender identity. I think that drives all of us that are marginalised or criminalised away from SRH care and also from UHC. And I think, as I said in my comment, we have to put the last mile first. And those who are excluded from having sexual rights, and that includes women who are denied access to safe abortion, and it includes the right to decide whether you have children or don't have children. I think these are rights that we are denied in many countries, and we have to put the last mile first if we're going to leave no one behind and actually achieve universal health coverage for all. because the stigma and discrimination when you have your rights denied keeps us away from what we're all trying to achieve, which is health for all, with no exception.
In their final comments, Ruth and Zandili touch on the digital aspects of universal health coverage, the importance of social media, and the digital inequality faced by many populations.
One of the things that COVID has forced us all to do is to attend so many Zoom meetings. But there is a huge digital inequality, not just between urban and rural, but between rich and poor, between privileged and those that have no privilege, between education and those that have little education. And that particularly affects marginalised communities. I'm super grateful for social media and enabling us to get our message out. But I think if we're going to do community mobilisation on the ground in every country, which is what we need, we can't just rely on social media. Building communities and building organisations led by communities is one of the strategies that's been acknowledged within certainly the global AIDS strategy, where it says that 60% of services should be led by communities, including community health workers, but not only community health workers. And within my movement, I'm sad to say that earlier today I heard of the passing of one of our leaders in India from COVID-19. She was part of a sex worker collective of all genders in Mysore in India. Name was Manjula. And they actually trained sex workers to become nurses, and they ran their own clinic and they employed their own doctors. And there were 12 sex workers who went through nursing degrees and worked in their own clinics. There are sex worker-led organizations in South Africa, in Pakistan, in Thailand, in Eswatini, across the world, who need to be part of our health response, including sexual and reproductive health, and the task shifting that's required to make UHC a reality for all.
As Ruth has mentioned, social media on its own is not enough, correct? And hence I outlined the different interventions that then took place in the community, because you're looking at two groups here. You're looking at the social media streets, which is what we call it, and you're looking at the actual community. So the social media element joining and integrating with the community is just another way of reaching out to that group that is not necessarily active in the community and wanting to join conversations where there are group discussions and so forth. So you just place the information. And another thing that usually assists is the modeling of a person that is living or is experiencing the issues that they are currently facing, which has been my greatest attempt, is trying to show the young people on social media that the challenges that they are facing, whether they choose to read through and access or not, it's really their decision. However, we cannot fully eliminate the social media aspect of it, because they are on social media and they are engaging each other in social media, and they are DMing and sending messages to people like me who play a role of bringing the information to them, the information that they are not being able to access at the healthcare facility.
Thank you for tuning in to this edition of Friday Podcasts. And thank you to Ruth and Zandili for their incredible and truthful commentary, and to UNFPA for your continued support and partnership. To learn more or to view the event in its entirety, please visit the .mom column on New Security Beat or follow us on Twitter @Wilson_MHI. If you enjoyed this episode, please subscribe to Friday Podcasts wherever you listen to podcasts.